Hello, I'm Amit Khot. I'm a hematologist and bone marrow transplant physician. I'm currently working in the clinical hematology department of the Royal Melbourne Hospital and the Peter MacCallum Cancer Centre. A large part of my role is carrying out bone marrow transplants for patients with a wide variety of hematologic disorders, including lymphoma. I usually explain this to my patients in a sort of 3 points. We need to have three boxes ticked off to consider that a stem cell transplant or a bone marrow transplant is going to be successful. So the first is we need whatever tumor, lymphoma, leukemia that we're treating, we need that tumor to be under very good control. So as close to a complete remission as possible. This is because transplants are designed to be, into inverted commas, mop-up strategies. They're not designed in the lymphoma setting to treat active or progressive tumors. So we have to find some modality of treatment which controls the tumor before we consider doing the stem cell transplant. So that is the first sort of point of eligibility. The second is overall fitness, and which means having these are procedures which can have a lot of side effects. So we need the body to have a certain degree of reserve and fitness to be able to withstand these side effects. So, for instance, if there are a lot of other ongoing problems which are unrelated to the tumor or to the lymphoma, which, say, for instance, kidney problems or significant heart problems or lung problems, these make the procedure very risky. So we have certain ways in which we determine whether we think that the risks are too high if there are other problems going on, and if we use certain tests to work this out. We use formal lung function studies, cardiac function assessment, kidney function studies, and a whole host of other tests to work out whether we think the risks are manageable and acceptable. And we have standard ways of assessing these with formal scores that we discuss these with all patients to make sure that the risks are well understood, because these are procedures which can have a degree of risk. And of course, we need a stem cell source. So and that depends on the type of transplant that we're doing, whether an autologous transplant and allogenic transplant. So we need, if it's an autologous transplant, we need the stem cells to be collected, and we're generally able to collect these successfully to the numbers that we need in most cases. But sometimes we are unable to do so. So obviously, if we can't collect the cells, then the transplant can't proceed. And in the allogenic transplant setting, that is the donor, we need to identify the appropriate donor, and there is specialized testing which matches the patient's tissue type with that of the donor, whether related or unrelated or cord. There are special tests which match what we call the tissue type. And it's only when we get an acceptable degree of match between the donor and the recipient that we are able to proceed. One of the questions I'm often asked is about age and age eligibility for a transplant. Over the years, we've learned that more than age, it is fitness, overall fitness, that is more important. Of course, as someone gets older, the chances of having other associated problems like heart problems or kidney problems or lung problems increase. but that does not mean to say that older adults in even above the age of 70 cannot be considered for these procedures. Of course, the decision is much more considered and discussed very actively with the patients in terms of the risks and benefits of these procedures, but what we've learned over the years is that biological age is more significant than chronological age when it comes to eligibility for transplant.